Alberta Primetime with Michael Higgins.
Welcome to Alberta Primetime. Ahead tonight, our politics panel on fallout from Donald Trump's 90-day pause on reciprocal tariffs. But first, changing the formula.
Patient-focused funding is a powerful tool that can fully account for the complexity of care given to every patient.
The health minister on announcing a new acute care funding model, one that shifts from global funding of hospitals to an activities-based model that ties dollars to the number and type of procedures performed. The Premier says by fostering competition within the system, costs will be driven down. Joining us now, Dr. Braden Manns, a physician and professor of medicine and health economics at the University of Calgary and a previous interim vice president at Alberta Health Services. Dr. Manns, hello, sir. Welcome to Alberta Primetime.
Thank you for having me.
All right, from a front lines perspective, what kind of shift does this represent in the delivery of healthcare?
So it's not as much as you might think. The Premier had that nice 7-minute description of what activity-based funding is, and Alberta Health Services was already doing some of that. So she talked about 3 parts to it, right? That you get a clear price for the service. So knee surgery, I need 2 nurses in the operating room. I need 1 nurse for every 4 patients in the recovery room. You need the hardware for the surgery. You need some supplies. So you agree on what resources are needed. You set the benchmark. AHS was already doing benchmarking against other hospitals within Alberta, similar hospitals, hospital wards, surgery, and across other provinces as well. So they were already doing the benchmarking. So then now you've got the price, you've got the benchmark, and the Premier talks about competition. Every hospital, every CSF is going to have to do the procedure for less than the price. Problem is that the competition is all going to be for the easy cases, the ones you can do really quickly, people that don't have a lot of complexity to them, the ones that can be done in the chartered surgical facilities, the ones that don't need an overnight stay. The competition is not going to be for the harder cases. Those are going to still be left in Alberta Health Services. And if you need the support of a hospital, then you do need to be operated on in the hospital. And then she talked about accountability. And again, we've really struggled in the healthcare system, but you can get accountability with a global budget. The government just needs to hold the hospital system, hold doctors accountable. And it's not just accountability for doing volumes, it's accountability for getting a good surgery, a safe surgery. And so are we going to have more accountability in this? I guess we'll see. Are we actually going to monitor the cases are being done safely? We'll see. I can tell you a little bit about what this is going to look like for hospitals as well, if you'd like.
Well, maybe first, how about this? Service-based funding, payment by results, payment by volume. Okay. What impact do you expect this to have on quality of care?
Well, we don't measure quality of care in chartered surgical facilities. We were measuring quality of the surgical care across hospitals, but that program in Alberta Health Services, that program actually closed a year ago. So we don't have as good a sense as we used to about what quality of surgery looks like. And in fact, a lot of the human resources and the infrastructure that we had for measuring quality in Alberta Health Services has been lost over the last couple of years with cuts to funding and with the changes that have happened, the restructuring.
Okay. Then on your point about hospitals, if it is that results are to be rewarded, how do you see hospitals adapting to a competitive environment? What does that look like?
So it's interesting in the surgery. So I'm not against activity-based funding, and I'm not against pulling surgeries out of the global budget. Ontario and Quebec did it. Alberta did it during the pandemic, actually, when the government provided extra funding for surgery catch-up. And actually providing hospitals funding specifically for surgeries increased significantly the number of surgeries that are being done, because it's no longer competing with an emergency room that is, stacked with patients who aren't able to get up to the hospital ward. So you actually protect that funding for surgery. The problem is it doesn't deal with our critical shortage of humans, anesthetists, operating room nurses. And so simply changing the funding formula, it's going to have a limited impact if we can't get more anesthetists. We struggled to, there's been a program piloting the use of respiratory therapists who are supervised to do anesthesia by an anesthesiologist who looks after 3 to 4 rooms with really highly trained respiratory therapists. But we've been unable to, that's been really difficult to scale that program because there hasn't been no billing code for the anesthesiologist. They run into some issues with using those respiratory therapists in the chartered surgical facilities, and the government's not sort of willing to put their foot down and push some of these solutions that we actually need. It'll get us more humans to actually do surgery safely.
Let me ask you this. How do you see this playing at a time when there are investigations and reviews underway into allegations of government interference in surgical contracts? Surgical contracts, a push the government continues to pursue.
Yeah, so it's interesting. There's challenges associated with chartered surgical facilities. Twice as expensive as the cost in AHS for similar cases. When you compare the easier cases, we're paying the chartered surgical facilities, or some of them, twice as much. They tend to do milder cases because you can get those through faster. And some of those cases actually probably don't need to be done. So we actually need to do a much better job of managing surgical wait lists. They create more variation in care. There is not one wait list for knee surgeries in Alberta. Every surgeon has a wait list for knee surgeries, and they manage it separately. Actually, now they're going to have 2 wait lists for knee surgeries, the ones that can be done in hospitals and the ones that can be done in chartered surgical facilities. The CSFs drain staff from the public system. They make it harder for, would you rather work in a chartered surgical facility from 7 to 5 during the day and not on the weekends? Or would you rather work in the hospital where you're going to be on call and you might get called at 3 a.m.? But yet the hospitals have to ensure that there's a surgeon and an anesthetist available. If you get appendicitis or your grandma breaks her hip, you're going to expect that the hospital staff is staffing their call schedule. And then we've seen that the CSFs are ripe for financial abuse. They were pushed, the additional facilities were pushed through very quickly. And I don't think there's enough staff to audit what actually happens there. There's no assessment of quality, and essentially AHS just pays the bills that CSF send over. So, after just saying that and this scandal, they're pushing more surgeries to be done in CSFs because activity-based funding is going to be, it's going to increase the number of surgeries that are done there. So we've just gotten badly burned. And before any reviews have been completed, we're doubling down.
All right. I'm afraid we're out of time. We have to leave it there. Good to see you, sir. Thank you kindly for providing us with your perspective this evening.
You're welcome.
All right. That's Dr. Braden Manns, a professor of medicine and health economics at the University of Calgary.